I have the privilege to invite our next speaker, who is Mr. Lovegrove. He's a well-known expert colorectal surgeon in the UK with very active, very long activity in IBD surgery. And he will talk us about a very difficult and debatable issue, the management of severe dysplasia and cancer in IBD patients.
Thank you, and thank you for inviting me to come and talk to you all today. I'd like to thank the organisers for their hospitality over the last few days as well. So, I'm here to talk to you about the management of dysplasia and cancer in patients with inflammatory bowel disease. I've got no conflicts to declare. So, to give you a bit of background, these are diseases of the bowel mucosa that are associated with an increased risk of colorectal malignancy. And if we look at all patients dying as a result of inflammatory bowel disease, 15% of these deaths are due to colorectal cancer. Most of the data from the published studies is actually derived from patients with ulcerative colitis, but a lot of this data is transferable to patients with Crohn's colitis. The other thing to consider, which is beyond the scope of this talk, is that in patients with Crohn's disease, there's also an increased risk of adenocarcinoma and lymphoma of the small bowel. So what are the risks for patients developing neoplasia in inflammatory bowel disease? There's the disease extent, the disease duration, with some centres saying there's a younger age at onset being a particular subset in terms of disease duration, family history, and the prevalence of primary sclerosing cholangitis. If we look at the disease extent, for patients with proctitis, there's only a very modest increase. Their standardised incidence ratio is only 1.7. This increases for left-sided disease, but in pancolitis, the standardised incidence ratio increases to nearly 15, and this is associated with a prevalence of colorectal cancer in these patients of 5.4%. With disease duration, the study by Eden from 2001 did a meta-analysis looking at various studies to try and determine where does the risk increase. And it's been well documented that from 10 years disease duration, then the risk of colorectal cancer begins to increase. It increases again further at 20 years. The risks are considered to be higher in those patients who've had juvenile onset disease, that is, those being diagnosed before the age of 18. If we look at patients who have ulcerative colitis and first-degree family relatives that have had colorectal cancer, and this may be a sporadic cancer rather than an IBD-associated cancer, with a first-degree relative under the age of 50, the relative risk of that patient developing colorectal cancer increases ninefold. If the first-degree relative was over the age of 50, then the risk is much smaller, it's only 1.7. But if we then compare these patients to the general population that don't have inflammatory bowel disease, if you have ulcerative colitis and a first-degree relative under the age of 50, your standardised incidence ratio of developing colorectal cancer is 180 times greater than the general population. These patients are at significant risk compared to the background population. If we look at primary sclerosing cholangitis and the effect that this has on patients with colorectal cancer, it increases the risk of neoplasia. About 21% of patients who have PSC and ulcerative colitis will go on to develop colorectal cancer, and their risk is 4.8 times greater than those patients with ulcerative colitis but no PSC. So how should we survey these patients? Based on Eden's data, the recommendations are we begin surveying at 10 years after diagnosis. These patients should undergo chromendoscopy, that is a dye spray colonoscopy. You'd use a high-definition colonoscope. Narrowband imaging is not an alternative to chromendoscopy. Ideally, surveillance should be undertaken when the patient is in remission. It's far more difficult to try and spot dysplastic lesions in an acutely inflamed colon. So the British Society of Gastroenterology has put together some guidelines and categorised patients as being either into low risk, which is normally those with a left-sided disease, or with Crohn's colitis affecting less than 50% of the colon. These patients can undergo 5-yearly surveillance colonoscopy from 10 years onwards. With intermediate risk, these patients normally have inflammatory polyps, or they've got a family history of colorectal cancer in a relative age over 50. they should be on a 3-yearly surveillance programme. But the high-risk patients include those who've had previous colonic strictures, those who've had previous dysplasia, they have PSC or have had a liver transplants for PSC, or they have a family history of a first-degree relative with patients under the age of 50. These patients need to be on annual surveillance. So when we look at dysplastic lesions, there's 3 main types of dysplasia that we're looking for. There's the visible dysplasia, and this can either be polypoid or non-polypoid, which was formerly known as flat dysplasia. But then there's also invisible dysplasia. So polypoid dysplasia, you have a lesion that's protruding more than 1 millimetre above the surface of the bowel mucosa. It's often possible to remove these endoscopically. If you can remove the lesion entirely, and there's no flat dysplasia in the surrounding mucosa, then a colectomy is not required. These patients can continue with regular surveillance as per the surveillance guidelines. Flat dysplasia is far more difficult to spot, and these 2 photographs are of the same lesion before and after dye spray. And this is why chrome endoscopy is preferable. Traditionally, flat dysplasia was considered an indication for colectomy, but with advancing techniques, high-definition scopes, it's now considered that these patients can continue with surveillance, providing the areas of flat dysplasia can be completely removed. Invisible dysplasia is more of a problem. These are the dysplastic lesions where you've taken a random biopsy, normally because you're doing a surveillance colonoscopy without availability of chrome endoscopy. So you've been doing your biopsies as per the guidelines, every 10 centimetres, 2 to 4 biopsies, and you then get some of them coming back as showing dysplasia. The first step should be to repeat the colonoscopy as a dye spray colonoscopy using a high definition scope. If you can find a visible lesion in the area where the dysplastic biopsies were coming from, and you can remove that lesion, then it is safe to continue with annual surveillance. But you need to have a chat to the patient and explain to them the risks and benefits of surgery versus surveillance. If there are no visible lesions, then colectomy should be advocated. St Mark's looked at some data in terms of the risk of having a synchronous colorectal cancer when you actually undertake a colectomy for dysplasia. So if the indication for the colectomy was low-grade dysplasia, on the pathological specimen, so not seen at the time of the colonoscopy, 25% of patients had a synchronous colorectal cancer. If the indication was high-grade dysplasia, 45% of these patients had a synchronous colorectal cancer. This is something that you've got to speak to your patients about in terms of the risks when trying to counsel them between future surveillance or surgical management of their disease. Colonic strictures can develop either in ulcerative colitis or more commonly in Crohn's colitis. There are increased risk of malignancy because biopsies can also be misleading. You may get a biopsy that just shows inflammatory tissue, but the malignancy is still there. And if these strictures are narrow and you can't pass the colonoscope through them, you can't properly survey them. It should always be advocated that colonic strictures are resected. For patients with ulcerative colitis, this should be in the form of a panproctocolectomy, but for Crohn's colitis, a segmental resection is considered safe. We've heard a lot about the management of colorectal cancer during this meeting. I'm not going to repeat a lot of the things that you've already heard. If you find a cancer at the time of undertaking a surveillance colonoscopy on somebody with IBD, the same rules apply. Biopsy the lesion, tattoo distal, test to make sure the tumour is staged appropriately with CT or MRI if appropriate, but beware, synchronous cancers are more common in patients with inflammatory bowel disease. If you've seen one cancer, there's a 25% chance that patient is going to have a second cancer. So what are our surgical strategies? We need to ensure that we can achieve oncological clearance. We should restore bowel continuity when it's appropriate, but we also need to consider what's the future surveillance for that patient. Panproctocolectomy should be considered the gold standard. It allows for complete disease clearance, it eliminates the need for endoscopic surveillance, and this is what all patients should be offered if they come to require surgery. However, not always is this appropriate. If a patient only has colonic dysplasia or malignancy and they've had rectal sparing, then a subtotal colectomy may be appropriate. If It may be a patient who actually wants to pursue a restorative operation, but they have other risk factors for restoration at the time of their cancer diagnosis, such as steroid use or the use of biologics. In these patients, it may be appropriate to undertake a subtotal colectomy, wean them off their medical therapies, and then plan for an early completion proctectomy with restoration once the conditions are more favourable. Also, in older, unfit patients, a subtotal colectomy may be appropriate if the patient is felt to be unfit for pelvic surgery if they've got a colonic lesion. More recently, Khan et al. Have been looking at whether segmental resection in older, frail patients can be considered safe for patients with inflammatory bowel disease. And a lot of these patients weren't fit for lengthy operations, but there is a risk that they may need to have some ongoing medical therapy. And they compared their outcomes between those having a segmental resection to those having a proctocolectomy. Their duration of follow-up was good, it was 9 years, and during that time there was no further development of colorectal cancer intraluminally in these patients. So for your very unfit patients, then this may be an option. But what about restoration of bowel continuity? The options are the ileoanal pouch procedure, an ileorectal anastomosis, or a continent ileostomy. So the ileoanal pouch procedure has been described in the late 1970s by Sir Alan Parks and John Nichols. Patients are able to achieve a good quality of life with this operation. The functional outcome is acceptable, the use of it is widespread, but there's a risk of them developing pouchitis in up to 40% of patients, and there's a risk of failure of 5 to 10% at 10 years follow-up. But if you undertake a pouch procedure, how should you do the anastomosis? A hand-sewn pouch anastomosis is generally advocated in the presence of rectal dysplasia or neoplasia, but it doesn't completely eliminate the risk of neoplasia of the cuff, and it may actually impair surveillance of the cuff since the lower end of the pouch is brought down inside of the rectal remnant. And there is a risk of patients developing cancer after their pouch procedure. Up to 16% of patients following a pouch would develop dysplasia of the rectal cuff, and about 1 in 1,000 would go on to develop a cancer. Patients at increased risk are those who have primary sclerosing cholangitis, those are undergoing a colectomy for either dysplasia or neoplasia, and those that develop type C mucosa of the pouch during surveillance. More recently, there's been some work looking at the use of ileorectal anastomosis in patients with IBD. This may be appropriate if they've had sparing of the rectum, may be used following a subtotal colectomy if they've had rectal inflammation, and you can then control that inflammation with the use of mesalazine. These patients can achieve good function, a good quality of life, but they require ongoing surveillance of the rectum, and if need be, then you can always convert to a pouch at a later stage. However, the authors do advocate caution if you're using this for patients with dysplasia or cancer, because they're going to be at increased risk of developing further problems within the rectum. The continent ileostomy kind of went out of fashion when the ileoanal pouch became so successful, but it's starting to make a little bit of a resurgence. And this can be done for patients after they've already had a pan-proctocolectomy. It means they can avoid the need for a stoma appliance, they can achieve a good quality of life, but is the procedures associated with high reoperation rates, between 25 and 35% of patients requiring further revisional surgery. The problems we tend to run into are that the valve mechanism can slip, leading to incontinence of the reservoir. You can develop fistulas around the complicated anastomosis of the reservoir, or the stoma itself can stenose down due to the repeated trauma of intubation. Worldwide, there's very few centres that actually have any significant experience with this procedure. So what about the long-term outcomes for these patients? This recent study has shown there's no difference in long-term outcome when compared to patients with sporadic colorectal cancer, with 5-year survival being the same between the two groups. So in summary, good surveillance of these patients is absolutely paramount. Endoscopically resectable dysplasia is not an indication for colectomy, but the cancer risk is higher in those patients when dysplasia is found. When it comes to operating, do not compromise oncologically. That is your first and foremost outcome. Restoration is secondary. Thank you.
Thank you very much. It is a very interesting and difficult topic, and I would like to emphasize that sometimes we need a second opinion the discrimination between low-grade or high-grade dysplasia sometimes is quite difficult, and especially for countries like Greece, that we do not have centers we need to ask for a second or third even opinion in order to decide what is the optimal decision for our patients. And another thing is, it is very interesting the issue with the continent ileostomy, and I would like to ask Professor Panis if they use this technique in order to improve their patients' quality of life.
I'm not sure with the cup pouch to improve the quality of life. I think for us there is no more place for this operation, because we do most of the time, in 80% we do pouch and 20% we do ileorectal. I agree with you. And in fact there is only a very small percentage of patients with failure of pouch where you can propose a cut pouch. But today in France, I think there is no more surgeon who do the technique. I think it's a very specialized technique. So I have just a comment on your conclusion. If you have a flat, low-grade dysplasia on UC patients, what do you say? You propose surgery or no?
So if it's flat dysplasia and you can identify it endoscopically and remove it endoscopically, then I would normally advocate...
No, I mean random biopsy.
Oh, and random biopsy.
Random biopsy, and you have low-grade dysplasia.
I would counsel the patient into what the risks are. So I'd make sure they're aware there's the 25% risk of missed cancer, and explain they need to be on annual surveillance.
So you don't operate, you surveil the patient?
I would give them the option, and I would talk them through the options.
Because for us, it's an indication of pouch.
Yeah.
If you have a flat, I agree with you, we check with a second pathologist, and if he say yes, it's real dysplasia, but it's low-grade dysplasia by random biopsy, we operate the patient.
Yeah. I normally lean them towards that, but you'll get some patients that, regardless, don't want to face the risk of surgery just yet, and will still continue with surveillance. But I make sure that they know what the risks are.
Because we have some terrible history of patients, because most of the time when you have a cancer, you have a quiescent UC with no symptoms. So the patient disappear and come back with a T3 rectal cancer. So it's a big problem. And the second, my last question is, if you have you decide to operate for example for high-grade dysplasia, you do oncologic resection or not? In other question, you do TME or you do closed rectal dissection?
So if there's dysplasia in the rectum, whether it's low-grade or high-grade, I would always do a TME. But I'd normally modify it over the sacral promontory to try and minimise risk to the nerves.
Okay, thank you.
Something else I would like. Okay, just one question. I need your comment. Whenever you have a rectal cancer in a UC patient and you have to go for a neoadjuvant therapy and then you proceed to a pouch surgery, what is the functional results of this pouch surgery? Do you have experience?
So there's very little data in terms of looking at neoadjuvant radiotherapy and pouch outcomes. When I was doing my research with Professor Tekis, we did look at some data from the Cleveland Clinic, and the data was very limited, but it didn't show a significant difference in functional outcome.
Thank you very much. So.